To the 44th dental combined rounds from the Department of Prosthodontics and Crown and Bridge on the topic Functional Rehabilitation of Hemisected Mandibular Mole. Modern dentistry aims to preserve the natural dentition, ensuring the patient's comfort while restoring the dentition. Within this paradigm, the long-term prognosis of a compromised molar is no longer judged solely on the condition of crown, but on whether at least one root can be predictably maintained, decontaminated, and biomechanically integrated into a definitive restorative plan. To achieve this, the retention of roots or a part of root in a multi-rooted tooth is very crucial to support the coronal restoration. Contemporary literature increasingly supports tooth retentive approaches such as root resection and hemisection protocols as biologically sound alternatives to extraction and implant placement in multi-rooted teeth. Preserved roots act as biologic abutments, providing proprioception, maintaining alveolar bone volume, and offering strategically positioned support and retention for fixed and removable prostheses. Starting with our case, a 52-year-old female named Zarina of Jaipur reported to the outpatient department of Mahatma Gandhi Dental College and Hospital with the chief complaint of pain in lower left back tooth region since 2 months. During this period, she consulted multiple dentists who advised tooth extraction due to poor prognosis. Seeking an alternative treatment approach, she visited our hospital for a second opinion. Coming to the history of present illness, pain started 2 months back, which was gradual in onset, mild to moderate in nature, aggravated by mastication and due to food lodgement, and relieved temporarily on medication. There was no association with bleeding or there was no history of recent trauma. While taking the past dental history, patient told that extraction was done with respect to 2/6 1 year back at a private clinic. There was no relevant family or medical history. Under the personal history, patient had a habit of mixed diet with no history of tobacco consumption. In the oral hygiene habit, patient was using fluoridated toothpaste with medium pressure brush with no interdental aids involved. On general physical examination, patient was conscious, oriented and responsive and had normal vitals. All the soft tissues were normal. Under hard tissue examination, a total of 31 teeth were present with dental caries with respect to 3/6 and 4/6, where 3/6 was tender on percussion. There was a missing teeth with respect to 2/6 with stains and calculus present. These are the intraoral images showing partially edentulous with respect to 2/6, root stumps with respect to 4/6, and dental caries with respect to 3/6. All other parameters were absent, but there was food impaction with respect to 3/6 and 3/7. During gingival examination, all parameters were normal except the position of 1-1, 2-1, 3-1 and 4-1 were 1 mm below the cemento-enamel junction and bleeding on probing was present with respect to 3/6. Further examination showed mobility, furcation involvement and loss of attachment with respect to 3/6. In the radiographic investigations, the orthopantomogram shows a missing 2/6, root stumps with respect to 4/6 and a decay on mesial surface of 3/6 as per the chief complaint. IOPA with respect to 3/6 was taken, which revealed evidence of mesio-occlusal decay with loss of tooth structure, radiolucenciate furcation suggestive of furcation involvement, diffused bone refraction continuous with periodontal bone loss, widened periodontal ligament space and loss of lamina dura. Based on radiographic, clinical and various investigations, the final diagnosis was asymptomatic irreversible pulpitis with symptomatic apical periodontitis with respect to 3/6. Based on the history, investigations and diagnosis, what do you think could be the treatment options based on these findings?
Either we can do extraction followed by implant, and we can plan a fixed partial denture followed by extraction.
If not extraction, then
endodontic treatment followed by periodontal regeneration.
Yes, sir. What do you mean by periodontal regeneration? Endodontic treatment with
So followed by periodontal regeneration surgery.
What exactly you mean by that? Would you like to explain it later?
Various treatment modalities were explained to the patient, that is extraction and without extraction. Under extraction, treatment options can be extraction followed by implant or the conventional fixed dental prosthesis. But as the patient was not willing for the extraction and keeping the natural teeth, the first two treatment options were avoided. The treatment options without extraction, that is the endodontic treatment with non-surgical periodontal therapy and root resections, were eliminated because complete disease with persistent pockets and root resection of tooth with compromised coronal structure would have led to poor long-term prognosis. Hence, hemisection was selected as a choice of treatment. Hemisection refers to sectioning of mandibular molar into two separate units by removing a diseased root and its associated coronal portion while preserving the remaining root and crown segment for subsequent functional rehabilitation. Functionally, the retained root-crown complex is restored as an independent premolar-like abutment or as a part of fixed partial denture, thereby maintaining arch integrity and occlusal support. Treatment plan was done in different phases. For elimination of persistent intracanal pathogens to achieve biologically and compatible seal through endodontic phase, to regenerate lost periodontal support and manage furcation involvement through periodontal phase, and to restore occlusal and structural function and facilitate long-term periodontal health through prosthodontic phase. In the phase 1, patient was referred to the Department of Conservative Dentistry and Endodontics, where root canal treatment of only the distal root of 3-6 was performed. These are the clinical and radiographic images with respect to 3-6 for the pre-operative and the post-operative root canal treatment. For the next phase of the treatment, I now call upon Dr. Pooja for further presentation.
Patient was referred from the Department of Conservative Dentistry and Endodontics after the completion of root canal for a comprehensive periodontal evaluation. During clinical examination, patient was completely asymptomatic with no presence of pain, swelling or purulent discharge. While doing gingival examination, in respect to 3-6, gingiva exhibited erythema, loss of firmness and slight edema indicative of localized inflammatory changes. The oral hygiene status showed supragingival and subgingival calculus and stain present, with probing pocket depth, loss of attachment, furcation involvement and mobility present in respect to 3-6. The IOPA post-root canal treatment that was taken after 2 weeks reveals horizontal and vertical bone loss with furcation involvement, loss of lamina dura and a widened periodontal ligament space around the mesial root. There was no emergency phase involved. Under the etiotrophic phase, ultrasonic scaling and root planning done with respect to maxillary and mandibular arch with a subgingival curettage done with respect to 3-6. Local antimicrobial therapy was advised and oral hygiene instructions were given to the patient. The re-evaluation of the phase was done after 2 weeks, which revealed a marked reduction in inflammation, but a persistence of a deep pocket and mobility with respect to 3-6 was still present. These are the pictures after the completion of etiotrophic phase. These are the probing pocket depth at baseline and at 2 weeks. The probing pocket depth depicts changes where we can see there were changes in respect to mesiobuccal, midbuccal, distobuccal, midlingual and distolingual pocket depth, but it was completely less. Hence, we planned for the surgery. Before the surgery, hematological findings were taken which were all under the normal parameters. Hence the surgical phase. Under surgical phase, hemisection was done. These are the armamentarium which were used. Initially, a full thickness mucoperiosteal flap was reflected and defect was degranulated and debrided. Tooth 3-6 was hemisected into a mesial and distal segment. After hemisection, mesial root and crown portion was removed. Bony site were refined using a Sugarman and Sugarloaf bone files. Bone graft was placed in the extraction socket. TPRF, that is titanium-rich PRF membrane, was adapted over the grafted site, and graft was repositioned with the sutures. These are the post-operative IOPA, which is taken immediate after the surgery. These are the post-operative instructions given to the patient, which included that do not eat until numbness is gone, avoid spicy, sharp, crunchy food for few days, avoid alcohol-containing products, avoid seeds or husk for 3 to 5 days, warm saline rinse thrice a day, and thorough but gentle toothbrushing twice daily on a non-operated areas. The evaluation of surgical phase showed uneventful healing with minimal post-operative discomfort, absence of infection, and satisfactory tissue approximation. Patient was kept under the maintenance phase where oral hygiene instructions were given and patient was reinforced to use interdental aids. The recall was done every 15 days, 1 month, and 3 months. After the 3 month, patient was referred to the Department of Prosthodontics, Crown and Bridge for prosthesis with respect to 3-6. These are the IOPA taken at the re-evaluation phases. Initially, it was a pre-operative IOPA at a baseline. Second one is in post-operative, immediately taken after the surgery. The third is a post-operative taken at the 1 month time period, followed by the 3 month IOPA. Now I would invite Dr. Harsh to move forward with the prosthodontic rehabilitation phase.
In the prosthodontic phase, diagnostic impressions were taken for the upper and lower arch using the irreversible hydrocolloid impression material. The diagnostic casts were evaluated for the treatment planning. For the mandibular arch, the distal segment of 3-6 and 3-5 were prepared as abutments, and for maxillary arch, 2-5 and 2-7 were prepared as abutments. The gingival retraction was done using mechanical retraction cord technique for the final impression. Final impression was recorded using a double-step impression technique with polyvinyl siloxane impression material. Light body elastomer was syringed around the teeth and the putty impression was reseated, ensuring the accurate reproduction of the finish lines. Maxillary casts were mounted on the semi-adjustable articulator using facebore records, and the mandibular cast was mounted using the interocclusal records. The provisional restorations were fabricated with autopolymerizing resin using the indirect technique and were cemented. At the metal coping trial stage, marginal integrity, path of insertion, interocclusal space, occlusal relationship, and proximal contacts were verified. Proper isolation followed by final cementation of porcelain-fused metal crowns was cemented using glass ionomer cement after verifying the marginal integrity, occlusion, and proper adaptation over the hemisected abutment. Floss in the interproximal areas was used to remove residual cement to avoid cement extrusion in the sectioned root areas. Proper marginal seal was verified to prevent micro leakage and secondary caries around the hemisected abutment. These are the radiographic images at pre-operative at baseline, post-operative after the surgery, and a follow-up of 3 and 6 months post-operative. Discussion. According to Domnish et al., in a systemic review in 2020, stated that the survival rate ranges from 38% to 94% in root resection and hemisections, which depended to a large extent on case selection and following specific endodontic, surgical, and restorative guidelines. Need for hemisection usually arises from localized and root-specific pathology. Periodontal etiology involved advanced vertical bone loss confined to one root, furcation involvement, root dehiscence or recession. Endodontic etiology involved non-negotiable or irreparable canal, iatrogenic perforation, vertical root fracture of one root, severe root caries or resorption of one root. Careful case selection is critical for predictable functional rehabilitation. First, for the anatomic considerations, in this case, bone loss was confined primarily to one root. Hemisection removes the diseased root, preserving the other root attachment. The patient preference and philosophy. Patient preferred to keep her own tooth and the treatment option was feasible. For the improved hygiene and pocket control, the removing the affected root helped in eliminating dip defects and pocket depth, reducing the plaque retention. For prognosis, as discussed earlier, evidence showed hemisection has a good survival rate. the anatomical fit and restorations, hemisection allows for a short span fixed prosthesis, avoiding long span prosthesis. And in long-term benefits, the hemisection preserves periodontal proprioception and avoids atrophy of alveolar ridge. Mokbel et al. In a systemic review in 2019 analyzed studies on root resection and hemisection for furcated molars, evaluating the survival rate which ranged from 40% to 100% and a follow-up from 6 months to 23 years. Half of the studies had survival rate of more than 90% with a follow-up period ranging from 5 to 23 years. Megarben et al. In 2018 evaluated the long-term results of root resection and hemisection of 195 patients with up to 40 years of follow-up. They concluded overall survival rate was 94.8%. Avaran et al. In a case report stated that if the appropriate case selection is put into consideration, the success rate of hemisection are high and the outcomes are predictable in compromised molars. Lin et al. In 2025 in his case reports stated that root resection and hemisections are reliable and predictable treatment modalities that should be considered viable alternatives to tooth extraction in appropriate cases. A randomized control trial stated that the periodontal regeneration is clinically viable and more economical alternative to extraction and replacement for teeth severely compromised by the presence of intrabony defect involving the apical portion of the root. Conclusion: compared with extraction followed by prosthetic replacement, this conservative approach offers the advantages of maintaining natural tooth structure, preserving proprioception, reducing surgical morbidity, and potentially improving long-term survival outcomes when case selection, execution, and maintenance are optimal. Overall, this case supports hemisection as a biologically sound and clinically viable alternative to extraction, reinforcing the value of interdisciplinary decision-making in contemporary practice. Lastly, for any case to succeed, importance of accurate prognosis assessment is very important. A strategic interdisciplinary approach can significantly improve outcomes even in cases with questionable prognosis. Collaboration among specialties is often key to shifting a compromised case towards a favorable prognosis. This case underscores that with coordinated care and patient compliance, even challenging cases can achieve predictable and long-term success.